This is Juan. He loves having a good time. And he also loves to eat and drink. But excessive eating and drinking can damage your liver. The liver filters the blood coming from the digestive tract before passing it through the rest of your body. Excessive amounts of food and drinks can leave your liver injured, which can lead to a non-alcoholic fatty liver and to more serious liver diseases. But by eating healthy and exercising and taking liver protectants, you can help prevent and reverse non-alcoholic fatty liver disease. Silicon and phosphatidylcholine are agents that help take care of your liver. Silicon protects your liver by effectively detoxifying it. However, it is poorly absorbed by the liver. Phosphatidylcholine repairs and replaces cell membranes and is well absorbed by the body when taken orally. Liver Prime uses the phytosome technology where silicon is combined with phosphatidylcholine, greatly increasing its liver absorption to provide triple liver benefits. It's an antioxidant that prevents cell damage, antifibrotic, which protects the liver from tissue scarring, and it helps regenerate your liver cells. So think about your liver and ask your doctor about Liver Prime.
Liver Prime, the first and only silly-phos for prime liver health.
Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us learn how to give the proper advice regarding the nutrition of patients with diabetes from Dr. Jin Uiho, who is an endocrinologist at the University of Santo Tomas Hospital and Manila Doctors Hospital. This session will be moderated by Dr. Katrina Paulino.
So, good morning, everyone. So, first of all, I would like to thank the organizing committee for this kind invitation. And the topic that was assigned to me is about nutrition in patients with diabetes. So, for this session, we will try to achieve the following objectives. Understand the role of nutrition therapy as the cornerstone in diabetes management. Learn to set realistic target goals. Describe the importance of total caloric intake versus macronutrient distribution. Compare the different dietary eating patterns and their advantages and disadvantages. And lastly, discuss other matters such as the use of sugar substitutes, alcohol consumption, sodium intake, and meal replacements. So this slide shows us that while nutrition guidelines have been available for so many years, they only get updated 4 to 6 years interval, and the changes are minimal. The latest 2019 ADA guideline now has a separate section emphasizing nutrition in prediabetes. And Canada and UK guidelines both were updated in 2018, also after a long interval. Nutrition therapy is defined by the National Academy of Medicine as treatment of a disease or condition through the modification of nutrient or whole food intake. And the Academy of Nutrition and Dietetics defines medical nutrition therapy as an evidence-based application of the nutrition care process provided by registered dietitian or nutritionist, and this, if properly done, can contribute to improvement in A1c by up to 2% reduction. So the goals of nutrition therapy is to promote healthy eating pattern, emphasizing nutrient-dense foods in proper proportion to achieve individualized metabolic parameters such as body weight, glucose levels, blood pressure, lipids, and of course to delay disease complications. Second is to address individual nutrition needs based on personal preferences, health literacy, access to foods, and food choices that are culturally congruent. Third, to maintain the pleasure of eating by providing non-judgmental messages about food choices. And fourth, to provide practical tools for day-to-day meal planning rather than focusing on individual macronutrients. Nutrition therapy is more easily said than done. There is confusing data from many different sources, and nutrition as a science is still evolving, and there's no strict definition of low carbohydrate diets, and dietary eating patterns are difficult to maintain over the long term. And most of the data that we have are based on short-term studies, and there is still no perfect agreement among professionals and societies as to the best practice approach to nutrition therapy. The role of registered dietitian cannot be overemphasized, and one should be also at least familiar with the overall diabetes care, including treatments, and the dietitian should do regular follow-up with patients to monitor their adherence. These are the essential components of medical therapy, nutrition therapy: assess, make a nutrition diagnosis, intervene by doing education and counseling, follow up and monitor progress, evaluate outcomes and make necessary changes. It is recommended that there should be at least 3 to 6 encounters between the registered dietitian and patient during the first 6 months, then once a year if possible. We go now to nutrition in patients with prediabetes. Lifestyle intervention is the initial step among patients with prediabetes. It has been shown in landmark trials that nutrition therapy can prevent progression to type 2 diabetes. In the diabetes prevention program, intensive lifestyle intervention resulted to 58% reduction of progression to type 2 diabetes in 3 years, higher than the control group and even the metformin group. And at 10 years, there is still 34% risk reduction. In another trial known as the docking study, in Chinese this is read as touching study, diabetes incidence was reduced by 43% versus the control group, and a similar finding was seen in Finnish prevention study that, at 7 years. The recommendation for prediabetes is patterned on the diabetes prevention program, wherein individualized medical nutrition therapy is provided by a registered dietitian to aim for dietary habit modification and regular physical activity of about 150 minutes per week to aim for about 7 to 10% weight loss. Weight loss is the key to diabetes prevention, and it has been shown that 5 to 7% weight loss can reduce the relative risk for future diabetes by about 50%. And as seen in this European diabetes prevention study, the weight loss of about 5% maintained at 3 years reduced diabetes by about 89%, and 1 kilogram weight loss will result to a 16% relative risk reduction. 10% weight loss can reduce DM risk by about 80%. And most of these trials focused on combination of diet and physical activity, and the diet focused more on caloric restriction than specific macronutrient distribution. And even in this Diabetes Canada guideline, over the whole spectrum of diabetes, whether in prediabetes, early diabetes, or longer disease duration, weight loss is always emphasized. And the best strategy is one that the patient can adhere long term. So, how about weight loss and diabetes remission for those who already have the disease? Is it still possible? So there are several hypotheses that hypocaloric diet leading to weight loss can reverse diabetes. And one such hypothesis is that 600 kilocalories per day for 8 weeks can reverse diabetes because this will reduce hepatic and pancreatic lipid levels, therefore normalizing insulin production and blood glucose levels. But this is considered as highly unrealistic due to difficulty in adhering to such diet. And the twin cycle hypothesis has also similar rationale. In one large trial lasting for about 8 years, the Look Ahead trial, intensive structured lifestyle modification led to significant weight loss, leading to partial diabetes remission in about 11.5% of the participants with type 2 diabetes compared with just 2% in the control group. And partial remission was defined as reversal to prediabetes glucose level from diabetes level with no DM meds for about 1 year. And in the recent diabetes remission clinical trial, also known as the DIRECT trial, in 2017, weight loss led to remission of diabetes in about 46% of the participants, and the remission rates is highest in those with the greatest weight loss. And complete remission was defined as reversal to normal glycemia with no anti-diabetic drugs for about a year. How about dietary pattern and diabetes remission? In one study by Esposito et al., a low-carb diet such as the Mediterranean-style diet led to a greater partial diabetes remission compared to low-fat diet, and the benefit was still noticeable even up to 6 years. So in contrast to the previous study, this study known as the Diet Fits RCT, there was no difference between low-fat versus low-carb diet in terms of weight loss at the end of 12 months. And both groups did show similar weight reduction, as you can see in the graph, wherein the low-fat was signified by the light gray and the low-carb diet was signified by the blue-green. So we now discuss the importance of each food group, or generally known as the macronutrients, namely the carbohydrates, fats, and proteins. So here are some misconceptions to diabetes: that avoiding all white food such as white bread, potatoes, pasta will cure diabetes. The fact is, there is room for all foods in a healthy meal plan, but choose good quality sources, for example, whole grains that are high in fiber, as a better choice than eating processed foods. There's no ideal percentage of distribution for the three basic food groups. And the bottom line is to individualize approach based on food preferences, as I've mentioned earlier. Same proportion of macronutrients for the general population can be adapted to patients with diabetes, but the total energy intake should not be in excess in order to attain and maintain appropriate weight targets. So this is how Diabetes Canada guideline would like to have the macronutrient distributed. It is still the same as the usual, so 45 to 60% for carbohydrates, provided the carbohydrates are of low glycemic index, 15 to 20% for protein, and 20 to 35% for fats. Carbohydrates generally has the strongest influence on immediate glycemic response, as expected, and that is the reason why low carbohydrate carbohydrate diet was favored by those seeking rapid results. However, this diet may not be appropriate for certain groups like those with eating disorders, renal disease, and those patients taking SGLT2 inhibitor, which is an oral antidiabetic drug, for fear of increasing the risk for diabetic ketoacidosis. And this diet is actually also difficult to maintain. Ideally, carbohydrate source should be rich in fiber, vitamins, minerals, with low added sugars, fats, and sodium. And the recommended daily allowance for carbohydrates is around 130 grams per day in order to serve bodily functions. So these are examples of healthy carbohydrates enriched with dietary fiber like pulses, such as beans, peas, lentils. Another are whole grains like oats and barley, and some fruits and vegetables like apples and berries. Carbohydrate counting is one way of monitoring carbohydrate intake, and it is a rough estimate of one serving of carbohydrate, which is equals which is equal to about 15 grams of carbohydrate. This is especially important in patients who inject mealtime insulin because this will lead to better glucose control, offers more flexibility in the diet, and simplify meal planning. So these are examples of carbohydrate exchanges equivalent to about 15 grams of carbohydrate. Examples are one slice of bread, one small, one small piece of fresh fruit, one-third cup of rice or pasta. So one way to choose the preferred carbohydrate is to look at the glycemic index. It is a scale that ranks carbohydrates by how much it can raise blood glucose levels. Low glycemic index foods such as non-starch vegetables and fruits can delay glucose absorption. Example of high glycemic index foods are refined grains like white rice, white bread, and potatoes, and these are best avoided. Moderate glycemic index foods include legumes and whole grains. But the method of cooking and the amount of fat and proteins consumed together with this can also affect the overall glycemic index. And the randomized controlled trials show that glycemic index has actually no significant impact on HbA1c, and there were mixed results on the improvement in the fasting plasma glucose. That's why the American Diabetes Association does not give so much emphasis on this. So these are the glycemic index of common foods, and the low glycemic index is less than 55. Moderate glycemic index is between 56 to 69, and the high glycemic index are those above 70. So there are proponents that glycemic load is more important than glycemic index because this take into account the amount of carbohydrate per serving and therefore is more predictive of the glucose rise. One review article on glycemic index and glycemic load opined that low glycemic index foods can reduce cardiovascular risk and improve glycemic control and satiety. So although glycemic index and glycemic load were not so much emphasized in the American Diabetes Association guideline, this is still advocated by groups like European, UK, and Canada nutrition societies. So I would just like to show you another data comparing low carb diet versus low fat diet, this time on all-cause mortality. And in here, the endpoint was the overall death. So here, it was shown that it is not the overall amount of the carbohydrate or the fat content in the food, but it is the unhealthy low carbohydrate sources, and unhealthy low fat food choices were actually associated with higher mortality. So if a patient indulge in other food sources in exchange for lowering the carbohydrate intake, and if a patient also indulge in other poor quality food sources in as a replacement for the fat, then overall this will still be associated with higher mortality. So therefore, emphasizing again the importance of choosing good quality sources of food. So this systematic review compared A1c reduction between low carb and low fat diet over the medium term, long term, and up to 2 years. You can see here that between 4 to 6 months, low carb diet is more superior than low fat diet in reducing HbA1c. And this benefit is extended even more highlighted beyond 6 months. However, at the end of 2 years, both diets showed no significant difference in the overall A1c reduction, with a point estimate lingering at neutrality. So this is a prospective cohort study and meta-analysis correlating the dietary carbohydrate intake and mortality rate. And this graph shows us the U-shaped curve of carbohydrate intake and mortality. As the carbohydrate intake is lowered up to 45% of the total calories and replaced by plant-based protein, the all-cause mortality is reduced. However, as the carbohydrate intake goes even further lower than 45%, then the risk goes up again. So if carbohydrate intake increases above 60% or goes below 45%, then mortality risk increases. So that's why most of the dietary guidelines would still aim for carbohydrate intake around this percentage between 45 to 60%. So we go now to sugar sweetened beverages. It has been shown that this type of beverages can increase the risk of type 2 diabetes, can lead to weight gain, increase the risk for kidney disease, and even fatty liver disease. And there's one meta-analysis which showed that consumption of at least one serving of sugar-sweetened beverages per day can increase the risk of progression to type 2 diabetes by about 26%. And consumption of regular soda increase risk by about 13%. And consumption of diet soda is not exempted. It can also increase the risk to the development of diabetes by about 8%. So what about sugar substitutes? So these are known as high-intensity sweetener, artificial sweetener, non-nutritive sweetener, low-calorie sweetener, and examples are saccharin, acesulfame, aspartame, stevia, which are probably commonly mentioned by our patients. So this, if used, can probably reduce the overall caloric and carbohydrate intake, but this still needs further confirmation. But use of this sugar substitute does not make an unhealthy choice healthy. It will only make it less unhealthy. And sometimes the problem is it may alter the feeling of hunger and fullness and decrease awareness of the overall caloric intake. So the better is to replace sugar-sweetened beverages not by this sugar substitute but with water. And this action can actually reduce the risk of diabetes by about 7 to 8%. And if ever a patient uses this sugar substitute, they should be cautioned on not to compensate this by taking additional calories from other food sources. So what about dietary fiber? So the minimum recommendation is to eat 14 grams of fiber per 1,000 kilocalorie per day as recommended by Dietary Guidelines of America. And better food sources will be the real food instead of supplements, because with this we can still get additional benefit like micronutrients and phytochemicals. So what about dietary fat? There's no ideal amount of total fat, and quality appears to be far more important than quantity. And according to AHA, American Heart Association, we have to limit saturated and trans fat intake. And Institute of Medicine and the Academy of Nutrition and Dietetics would like to limit fat intake between 20% to 35% of the overall caloric intake for the day, for both the general population and for type 2 diabetic patients. It can also be this range, but should be individualized. So these are some of the dietary fats we have. Better ones are the monounsaturated and the polyunsaturated fats. Sources are as follows. For the MUFA, for monounsaturated fat, we have the canola, peanut oil, and olive oil, avocados, and the nuts. For polyunsaturated fat, we have the sunflower oil, corn oil, soybean, flaxseed, and plant-derived oils like walnuts, flaxseed. So saturated fats are usually from dairy products, coconut milk, and palm oil, and they are best avoided. And trans fat are those coming from margarines, hydrogenated vegetable oil, and we should also avoid this as much as possible. So PUFAs are liquid in form at room temperature, and this is one clue for us if we are taking a PUFA versus a saturated fat. And this, as I've said, can come from vegetable oil. And PUFA have shown consistent benefit in terms of improving metabolic parameters, and has also been shown to prevent coronary artery disease in observational studies. Another source of PUFAs are the omega-3 fatty acids, and it is advised to have 2 servings per week uh, with fish as the source, because it has been shown to reduce sudden cardiac death among healthy adults. And sources of these can be salmon, tuna, mackerel, sardines. Another omega-3 fatty acids is in the form of alpha-linolenic acid, and sources are plant-based like walnuts, flax seeds, chia seeds, and soybeans. So saturated fats, as I've said, and trans fats should be avoided, and they appear solid at room temperature. And the guideline usually will tell us to limit this to less than 10% of our total calories for the saturated fat, and as much as possible 0 for the trans fat. And based on 3 RCTs, that limiting saturated fat and the cholesterol intake can reduce the LDL levels by about 9 to 12% versus the standard Western type diet. And trans fat has been mandated by the FDA that it should not be included in food beginning June 18 of 2018, because it has been shown to increase all-cause mortality. So monounsaturated fats are those fats coming from olive oil, peanut, avocado, and meta-analysis have shown that it can also improve metabolic parameters, especially among type 2 diabetic patients. So bottom line is, choose the right kind of fat. So eat more of this, the MUFAs and the PUFAs, and eat less of this, the picture you see below, which are a great source of saturated and trans fatty acid and cholesterol. So what about total protein? Some comparisons of protein amounts have demonstrated differences in diabetes-related endpoints. And in this 12-week study, higher protein intake by about 30% actually can decrease weight and fasting glucose levels. And however, in one meta-analysis, a higher protein intake, about 25 to 32% versus the usual 15 to 20%, did not show statistically significant improvement in fasting blood sugar and other lipid parameters. Although initially there was an improvement in HbA1c by about 0.5% for the higher protein intake. So this protein intake can become an issue, especially when a diabetic patient faces now a kidney problem. So the average daily level of protein intake in patients who still don't have diabetic kidney disease is around 1 to 1.5 gram per day, 1 to 1.5 gram kilocalorie, 1 to 1.5 gram per kilogram body weight per day, or 15 to 20% of the total calories. But there is no evidence that lowering further the intake of protein below this level will improve the overall health among type 2 diabetic patients. But in patients who already have diabetic kidney disease, those with albuminuria and or reduced EGFR, the recommendation is to take no greater than 0.8 gram per kilogram body weight per day of protein. However, studies have shown that further lowering beyond this limit of 0.8 gram per kilogram body weight per day will have no further benefit on the metabolic parameters, cardiovascular risk, and even in the renal decline. And the Joslin Diabetes Center actually advocates a higher protein intake among those who still don't have diabetic disease because this may contribute to increased satiety. So we go now to the different dietary eating patterns for diabetes. So eating pattern relates to when, what, how much to eat on a daily basis. And epidemiologic studies have shown that there are three eating patterns that are related to lower risk for developing type 2 diabetes, and these are the Mediterranean style diet, vegetarian, and a dietary approach to stop hypertension, or the DASH diet. And surprisingly, the low carbohydrate eating pattern actually showed no effect. So these are the different eating patterns. So uh, briefly, Mediterranean style diet, it emphasizes on plant-based food and with the olive oil as the principal source of the dietary fat. And red meat is eaten in low amounts. Wine is taken in low to moderate amounts. For the vegetarian diet or the vegan diet, these are the two more common approaches and also advocated by the guidelines. It is plant-based and devoid of all flesh food. But for the vegetarian diet, eggs and milk or dairy products are sometimes allowed. But for the vegan diet, all animal-derived products are not allowed. So the low carbohydrate diet uh, emphasizes vegetables and protein coming from uh, lean meat, and may also include fruits, and to avoid starchy and sugary food. In general, the caloric intake for the low carbohydrate intake for the distribution is that only about 26 to 45% of the total calories will be for the carbohydrate group. For the very low carbohydrate diet, it is almost similar to the low carbohydrate eating pattern, except that the the carbohydrate allocation will be less than 26% of the total calories. So the DASH diet emphasizes on vegetable, fruits, and low-fat dairy products, and may also include reduced in sodium content, and also minimize the red meat and processed foods. So the Mediterranean diet, as I've said, is rich in mufas, olive oils, and nuts, and it demonstrated mixed effect on the metabolic parameters. But in one trial in 2008, which is a 2-year trial among type 2 obese patients, the calorie-restricted Mediterranean-style diet overall showed lower fasting blood sugar than the low-fat group after 2 years of study period. But the lowest A1c reduction or the greatest improvement in HbA1c was seen in the low carbohydrate group. So most of the meta-analysis done on Mediterranean diet showed improved outcomes in the glucose control, body weight, and cardiovascular risk factors. And in one study, the PREDIMED study, which is actually one of the large studies and longer trial period, 4-year trial at that, which involved in 50% of its subjects with diabetes. So the Mediterranean style eating pattern utilized in that uh, intervention group was able to improve glucose control and with decreased need for glucose lowering medications, and was able to show lower risk of cardiovascular death versus the saturated fat and trans fat. And therefore, if we replace saturated fat with PUFA, we can get a better lipid parameter. But if we replace the um, saturated fat with carbohydrate instead, then it may reduce initially the bad cholesterol, but eventually it can increase triglyceride and lower HDL. So what about vegetarian eating patterns? So it has also shown mixed results in terms of the metabolic parameters and cardiovascular risk factors. But the two meta-analysis was able to show A1c reduction by about 0.3 to 0.4%. And however, there was no significant effect on the lipid parameters and blood glucose levels and even blood pressure in one meta-analysis, even though it was able to show to induce a 2 kilogram weight reduction. So the low-fat eating pattern, which is the one utilized in the Look Ahead trial, which actually I was able to mention in the earlier slide regarding the weight loss and diabetes remission. But one of the aim of the study was to compare the metabolic parameters, the overall benefit on the glucose level, and it was able to show in that study that the calorie restricted low fat eating pattern with the use of structured weight loss program, sometimes with the use of meal replacement, was able to improve the overall metabolic parameters and the quality of life. However, there was no additional benefit on the cardiovascular risk reduction versus the control. And some of the systematic reviews concerning low-fat eating pattern did not show consistent improvement in glucose control. So the low carbohydrate or very low carbohydrate eating pattern are some of the most well-studied eating patterns for diabetes management. But in one meta-analysis, comparing low carbohydrate versus very low carbohydrate diet, although the very low carbohydrate diet was able to show superior A1c reduction than low carbohydrate diet at 3 and 6 months, but at the end of 12 months and even 2 years, there was no significant difference between these two eating patterns. So the DASH eating pattern is a dietary approaches to stop hypertension eating pattern. And in one small 8-week study, it was able to show improvement in lipid parameters and blood pressure and reduction in HbA1c. And in one trial wherein DASH diet was combined with physical activity, it was able to show lowering of blood pressure, however, no difference in the uh, metabolic parameters. So what about intermittent fasting? So this is one um, uh, way of eating pattern which has been gaining popularity in the recent years. However, we have to remember that this is not a particular type of eating pattern, but instead it focuses more on when you eat instead of what we eat. So there are many different varieties, and there is the true fasting, wherein there's no food during the fasting period, and there's the modified one, wherein less than during the fasting period, the patient can still eat about less 25% or less of the original food intake, and it can be on an alternate day basis, or so one full day fasting alternate with unlimited food intake. It can be time restricted, wherein the food intake is just the fasting is restricted between 2 to 12 hours, or periodic, wherein the fasting occurs on 1 to 2 consecutive days of the week, and 5 days of the week the patient can have unlimited food. So overall, intermittent fasting, um, in 3 studies, consecutive days of full day fasting, um, or by fasting 16 hours per day or more, may result in weight loss. However, there was no improvement in HbA1c. And in another study wherein eating schedule was confined to just 6 hours versus 12 hours, the eating schedule just confined at 6 hours showed superior results in terms of improving the metabolic parameters. However, in one study wherein they compared energy restriction method, 2 days of severe energy restriction versus chronic energy restriction, meaning 2 days of low calorie diet, 600 kcal in a week, and then versus 1,000 to 200, 1,200 to 1,500 calories on a daily basis. Both method showed similar reduction in HbA1c. So ketogenic diet is also one diet that is sometimes being asked by our patients. However, we have to remember that there are still lack of long-term data regarding this, especially among diabetic patients. So, and there is caution regarding the use of this diet for patients who already have disordered eating habits, and those at risk for ketosis, and those, as I've said, those that are on SGLT2 inhibitors. And the proven benefit of this may be for the neuroprotection, and probably more for just for weight loss. And we have to be mindful of the long-term severe side effects of this, like the ones listed in this, like hyperuricemia, nephrolithiasis, electrolyte imbalance, pancreatitis, and some reported death. So what about meal replacement? So meal replacement is available commercially, and it can actually replace 1 or 2 meals per day. And it has been shown in randomized controlled trials that it can promote weight loss compared to conventional diet, and it can also reduce the need for antidiabetic meds for up to 1 year. And this is actually one strategy that was included in the Look Ahead trial, wherein there was significant weight loss maintained even up to the 8th year. And this is also one strategy that was used in the diabetes remission trial. And the meta-analysis for meal replacement was able to show that it can reduce weight better than energy restriction alone for 6 months. So these are the comparisons of the different dietary interventions, and this is published in Diabetes Canada guideline. And you can see that for the A1c reduction, we can either see this in the low glycemic index diet, in the high fiber diet, low protein diet, but neutral or not seen. This benefit is not seen among low carbohydrate diet, surprisingly. And in terms of the dietary pattern, the vegetarian diet, DASH diet, and the Mediterranean dietary pattern all showed reduction in HbA1c. In terms of cardiovascular benefit, almost all of these dietary patterns will reduce cardiovascular risk, except for low carbohydrate diet and high protein diet. Other advantages of this dietary pattern will be improvement in the metabolic parameters and weight loss for the high MUFA diet and for the vegetarian and the DASH diet. But disadvantages will be like for the high fiber diet, there can be some transient GI side effect. And for the low carbohydrate diet and the high protein diet, there can be increased renal load. And for the vegetarian diet, there can be some nutritional deficiency in terms of vitamin B12 deficiency. So these are just some pictures showing you the different diet, the Mediterranean diet. So focusing on more on the olive oil, the nuts as forming major part of the diet. Then the vegetarian diet or the vegan diet, wherein fruits and vegetables form majority of the major part of the diet. And the DASH diet, also with uh, whole grains and vegetables, but emphasizing on low salt or empty salt categories, and avoiding the processed foods. So what about alcohol consumption? So alcohol, if taken moderately, can actually be associated with lower incidence of diabetes. So what is allowed is 1 drink per day for women and 2 drinks per day for men. And there is a U-shaped relationship, so J-curve, for the alcohol dose and diabetes risk. And if one will stick with the allowed drink per day, then probably this amount of alcohol can actually be beneficial. But one should not advise or encourage abstainers to start consuming alcohol. So these are the different uh, drink per day based on the type of alcohol source. Like this is this is called 1 drink per day. For beer, it's about 12 ounce. For spirits, about 1.5 ounce, and for wine, 5 ounce. So this is equivalent to about 15 gram of alcohol content. So sodium intake, uh, if limited to around 2.3 grams per day, was demonstrated to have beneficial effects on blood pressure. And in one analysis of a secondary analysis of the on-target trial, wherein uh, lowering sodium intake to less than 3 grams per day or increasing sodium intake beyond 7 grams per day were both associated with increased mortality in type 2 diabetic patients. So this is just a comparison of the different dietary guidelines from Diabetes Canada, Diabetes UK, and American Diabetes Association. So the role of everybody agrees that the role of registered dietitian is very important. Weight loss should be emphasized with and the macronutrient distribution is actually flexible and can be individualized. For Diabetes Canada, they give us this recommendation for the amount of carbohydrate, fat, and protein. So 45 to 60% for carbohydrates, 20 to 35% for fats, 15% to 20% for protein. But for Diabetes UK, they only emphasize to restrict fats to less than 35% and 10% for the less than 10% for the saturated fat, but no specific amount for the carbohydrate and proteins. And for the American Diabetes Association, there is also no specific guideline, but they would like to maintain the same as much as the what we advise for the general population, but individualized approach. So carbohydrates can be restricted to about 45%. And with that, the amount of fat coming from PUFAs can be increased to about 40%. So both Diabetes Canada and Diabetes UK would like to put an emphasis on the low glycemic index, and but ADA doesn't put much weight on that. And then the dietary patterns that are recommended by different guidelines are as follows. So what is common among all the guidelines are the Mediterranean, DASH diet, and vegetarian diet. For the dietary fiber, this is also emphasized, and the minimum intake as advised by ADA is about 24 grams per day. This is around 14 grams per 1000 kcal per day. And sugar sweeteners can be taken, but limit to less than 10%. That is for Diabetes Canada and Diabetes UK. And for ADA, it is best avoided. So the rule is to make individualized approach based on personal preferences and culture, and emphasize on nutrient dense sources. Avoid refined carbohydrate, sugar sweetened beverages, and saturated fat and trans fat. So in summary, nutrition plans should be individualized and should meet specific needs based on the uh, individual preferences. There's no one size that fits all, and early referral to diabetes self-management education program, which includes nutrition counseling by a registered dietitian, uh, should be performed with periodic reassessment. And try to achieve a weight loss of about 5% through lifestyle modification. So there's no ideal percentage of distribution of the macronutrients. And again, so individualized approach is the key. And remember to take into consideration the overall caloric intake of the patient. And this should be in keeping with the target weight goal of that individual. And the best is to replace sugar sweetened beverages with water, and non-nutritive sweetener may be used, but careful not to compensate this with additional calories. Protein intake is pretty much similar to the general population, with emphasis on lean meat and plant-based protein. Mediterranean diet is good since it can improve glucose and lower cardiovascular risk, so as with the DASH and vegetarian diet. But further research is still needed to define the optimal macronutrient distribution. There's no clear evidence regarding dietary supplementation unless with underlying deficiencies. And then just stick to the allowed alcohol per day, 1 drink for women, 2 drinks per day for men, and limit sodium intake to 2.3 grams per day. So let me end this talk by quoting Hippocrates. Let food be thy medicine, and medicine be thy food. So thank you for listening.
The city is in pain, plagued by acid-related disorders that affect the lives of many. In this time of need, a hero emerges. One who will bring gut justice and relief, locked and loaded to overcome acid and optimize relief. Agent 00 is omeprazole omepron. Omepron comes in 20 milligram capsule, 40 milligram capsule, and 40 milligram vial. Omeprazole omepron delivers gut justice with its sustained relief. Compared to H2RAs, omeprazole delivers better, longer symptom relief, as shown in a comprehensive 8-week-long study, making it an ideal choice in suppressing acid. Omeprazole in omepron also exhibits remarkable efficacy in healing acid-related disorders versus H2RAs, and similar efficacy compared with other PPIs, showing that omeprazole is as clinically superior as other PPIs in the class. Omeprazole omepron also comes armed with safety as it interacts with clopidogrel. A study has shown omeprazole to have no significant inhibition on the action of clopidogrel, though known CYP2C19 substrates like omeprazole are said to reduce the effect of clopidogrel. It was found that omeprazole is extensively converted to its metabolite, 5-hydroxyomeprazole, suggesting that omeprazole is not a CYP2C19 substrate and thus safe for use with clopidogrel. So acid-related diseases, beware! Gut justice hits hard with double O's. Overcome acid. Optimize relief. Omeprazole omepron. By Westmont.
For the highlight of this postgraduate course, let us be inspired as we hear from Dr. Bong Javier. Please proceed to www.tiktok2021.com and click on the Distinguished Alumnus Lecture in the Plenary Session tab.